Hello and welcome to the latest episode of our psoriatic arthritis podcast series, alongside our rheumatoid and axSpA series podcasts. We'll be bringing you monthly slide decks to help keep you up to date with the latest research and publications in the field of psoriatic arthritis. Hi, my name is Peter Nash from the Professor of the School of Medicine, Griffith University in beautiful downtown Brisbane. And joining me today is Philip Mease, Director of Rheumatology Research at the Swedish Medical Centre and Professor at the University of Washington School of Medicine in Seattle. We also have Laura Coates, who is Associate Professor at the University of Oxford's Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Sciences. Hello and welcome to both of you. Today we're going to discuss a couple of papers that are important in the field of psoriatic arthritis, and they're highly relevant topics in the field, including the updated 2023 EULAR recommendations for the management of PsA, recently published in Annals of Rheumatic Diseases, and improvements in patient-reported outcomes following treatment with the relatively new TYK2 inhibitor, deucravacitinib, in arthritis care and research. To begin with, I'll hand over to Philip. Welcome, Philip.
Thanks so much, Peter. So we'll be discussing a major publication that is lead authored by Laura Gosek called EULAR Recommendations for the Management of Psoriatic Arthritis with Pharmacological Therapies, 2023 update. Both Peter and myself were co-authors on this, part of the working group that came up with these recommendations. As you know, periodically, both the EULAR group as well as the GRAPPA group come out with treatment recommendations, trying to update them as new therapies come about and new paradigms of thinking about the treatment paradigms emerge. Laura has been the lead author and leading light for the GRAPPA recommendations, which were last published in 2019. So this is a updated review, and again, it's focusing on drugs, and it acknowledges that there have been new developments, significant new developments since last published in 2019, and in particular, there's new safety data that came out about JAK inhibitor therapy, and so there's a increased emphasis on thinking about safety as we're algorithmically thinking about what treatments to recommend for our patients. This 2023 update focuses on not only musculoskeletal manifestations that are the full spectrum of psoriatic arthritis, which includes arthritis, enthesitis, dactylitis, spondylitis, but also the skin and nails, and then extra musculoskeletal associated conditions that include things like Crohn's disease, ulcerative colitis, and so forth. And all of these need to be kept in our minds as we're thinking about treatment. So in this way, these EULAR guidelines come closer to the GRAPPA guidelines, which have always focused on a domain-specific set of considerations for choosing treatments. The way in which this was the whole enterprise was constructed was that there was the choosing of a overall working group and a steering committee. There were 33 experts that including the steering group members, and almost half of them had not participated in the 2019 update. So this was fresh blood. In October of 2022, the steering group met. These were 8 rheumatologists, a dermatologist, an infectious disease specialist, a patient research partner, and 2 health professionals. Then during the late fall and winter, there was a systematic literature review and there were specific questions that were asked as they were going about looking at the efficacy data. In April of 2023, There were recommendation suggestions, and there were multiple rounds of voting that began then and continued through May of that year. And there was a certain level of agreement that each of the working group members were asked to provide. So here are some of the results. So the overarching principles remain similar to the 2019 update. 3 were unchanged, 3 were slightly reworded. And there was one new principle, and that was that the choice of treatment should take account of safety considerations regarding individual modes of action to optimize the benefit-risk profile. What does that mean? So in particular, in relation to the oral surveillance study, there was acknowledgement that there was a slight difference between JAK inhibitors and TNF inhibitors in terms of cardiovascular risk, malignancy risk. And so one should think about, who is this patient in front of us? How old are they? What are their comorbidities? In particular, do they have some cardiovascular risk factors and so forth, as we're going about thinking about choosing therapy. There was one new recommendation in terms of non-topical pharmacologic treatments, that the choice of the mode of action should reflect non-musculoskeletal manifestations related to psoriatic arthritis. So that includes not only skin and nails, but also the intestine in terms of inflammatory bowel disease, the eye in relation to uveitis. For clinically relevant skin involvement, the treatment preference is an IL-17A inhibitor, an IL-17A and F inhibitor, an IL-23 inhibitor, or an IL-12 inhibitor. All of these have been shown to have very good efficacy in the skin. For uveitis, the treatment preference is monoclonal antibody form of a TNF inhibitor, for which we have good evidence of treatment of uveitis. For inflammatory bowel disease, the treatment preference is a monoclonal TNF inhibitor, or an IL-23 inhibitor, an IL-12/23 inhibitor, or a JAK inhibitor, all of which have shown benefit in inflammatory bowel disease. And in terms of updates to the overall algorithm, phase 3 and 4 were modified to emphasize consideration of non-musculoskeletal manifestations and risk assessments for JAK inhibitors. For example, keeping in mind the more elderly patients, the patient who's a smoker, the person who has known cardiovascular malignancy risk, one should think about that as we're thinking about whether or not to use a JAK inhibitor. So to conclude, the 2023 EULAR recommendations provided an updated consensus on the pharmacologic management of PsA based on both clinical evidence as well as expert opinion discussed within the working group. A new overarching principle and recommendation were added for the 2023 update related to safety. The mode of action choice should consider risk-benefit profiles and non-musculoskeletal manifestations, and the acknowledgement that these recommendations need to be updated regularly as new therapies emerge and we have new safety data coming out.
Thanks, Philip. So, Laura, can you tell us your thoughts about the importance of guidelines and perhaps the differences between the GRAPPA and the EULAR guidelines? They're both now becoming more domain approached, but GRAPPA's never really tried to give a treatment algorithm because of lack of evidence, really. So what's your thoughts about guidelines, the importance of them, and the major differences that you see between the two groups?
Yeah, so I think, like Philip said, they are probably becoming a bit more similar, which is useful. I don't think we want lots of different guidelines that look completely different for clinicians. That would be very confusing. And obviously they're based on the same data, so they should roughly say the same things. But as you said, actually we don't have the evidence for a lot of the questions that we would like to answer in creating an algorithm. We have lots of studies that tell us that drugs A, B, C, D, E work better than placebo, but we don't have many head-to-head trials or sequencing studies things like that. And so it is much more difficult to create an algorithm or provide kind of definite advice about how to choose therapies. And I think there is some good information in there, but it also does highlight where we're lacking data and where it would be useful to have additional research to answer some of those questions. But I think treatment guidelines fill a very practical gap. We have more and more therapies available. People may not be aware of the latest data or how the drugs compare or what sort of things they should be taking into account. Thinking about, a preference depending on skin psoriasis, for example, or related conditions like inflammatory bowel disease. And so it's not just having to be up to date with the rheumatology studies, it's also thinking about dermatology literature and IBD literature, which is really useful when we're choosing therapies for patients in clinic.
So Philip, the US scene, how are these guidelines thought of? ACR published their own guidelines, which are a very different set of questions being answered. Are they useful in the US? Are they being considered in the US?
Yes and no. So there's several ways in which they're important. One of them is for payers. For example, payers want to know that whatever drug they're having in their formularies have authoritative evidence behind their use in terms of efficacy and safety to be justified. So that's an important thing for payers. I think clinicians variably use them. The ACR guidelines are already quite outdated, and we don't have another instance of updating them coming forward. As you may recall, they called for use of TNF inhibitors as the first-line agent ahead of methotrexate and other agents. I think increasingly that there's no particular reason for that, including I would think that IL-17 inhibitors or IL-23 inhibitors could readily be used as first-line treatment, as well as TNF inhibitors, and actually may have a slight safety advantage. So I think that they're useful, especially for younger clinicians who are just getting into the care of patients and are sort of trying to sort out what are all these treatments in front of us, and for payers.
And Laurie, Philip specifically discussed the JAK issue. Any thoughts on the role or the place of JAKs in the treatment algorithm? Because I do believe, Philip, we work very hard not to say throw the JAKs out, because they're here to stay whether we like it or not, but just to be careful, stick with the EMA rules for the time being until more evidence is available, and use them in the appropriate person. Laura, what do you think of where the JAKs should sit?
Yeah, and I think you've outlined a sensible approach, which sort of fits with both guidelines, really. I mean, EULAR a little bit put them, as very much a second line option, but actually, from a European perspective, we're nearly always using biosimilar TNF as a first line because the costs are so low that most healthcare settings require that across Europe. So actually, most of the time, if you're thinking about a JAK inhibitor, it probably is going to be second line, or it's going to be a very specific patient where you can't use a TNF, for example, and probably a small number of them. So I think it's treating patients as an individual. It's thinking about sensible precautions around age and cardiovascular risk, and having that conversation with the patient. And I think that very easily helps you decide. Some patients are very risk averse and wouldn't want to try it and are very nervous. Most patients, if you explain it and they know that they're in the safer group, if they're younger, and if they don't have any risk factors already, they generally don't have a massive concern, whereas patients obviously who are older or have cardiovascular risks are probably going to be less keen, which makes sense and sort of fits with clinically what we would advise as well.
Excellent. So I think that, as you say, there is this marriage of the two over time. We look forward to the ACR update when it finally comes. because they took a very different approach to how they made questions and answered questions and recommended therapies. So, Laura, would you like to move on to the second paper, which is entitled Improvements in Patient-Reported Outcomes with the TYK2 inhibitor deucravacitinib?
Yeah, so this is obviously one of the new therapies that sort of has been discussed as an up-and-coming therapy and treatment recommendations, and there's been a lot of interest in the TYK2 inhibitors, particularly I think with the excitement over JAKs and safety, and then the decision to kind of class TYK2 inhibitors as a separate type of drug and not put the same warnings of these. So this is data from the phase 2 trial of deucravacitinib in psoriatic arthritis, and a number of us were co-authors. So this was looking really at patient-reported outcomes from the phase 2 trial. This was a study looking in patients, some of whom had failed conventional DMARDs, some of whom had failed TNF. And obviously, we have a lot of drugs out there, but as you know, you've just seen in the EULAR recommendations, we do kind of use a good variety of these. There are good reasons why we would pick one drug or another drug for particular patients, and there's still a big unmet need out there. So there's still a need for more medications available, and I think we're still trying to work out where drugs like deucravacitinib will fit in that treatment algorithm. So obviously this is an oral therapy, it's a TYK2 inhibitor, it's been shown to have superior efficacy to apremilast in psoriasis, and previously been shown in the psoriasis trials as well to be effective for skin. So this was looking at patients who had active psoriatic arthritis, very typical for the phase 2 trials, and a mix of conventional DMARD failures and TNF failures. And they were randomized either to receive placebo, a lower 6 milligram dose of deucravacitinib, or a higher 12 milligram dose. And then they looked at week 16 compared to placebo, with a number of standard patient-reported outcome measures really that we include in the trial. So this is phase 2, it's still relatively small. There's 203 patients included in the analysis, and then they're obviously split into those 3 treatment groups. About a quarter of them were felt to have axial PsA, but there wasn't any imaging done as part of the trial. And when you look at patient-reported outcomes, unsurprisingly, we've already seen the clinical data from these trials showing a benefit. There is an improvement in quality of life. So with SF36 MCS scores, with the PsA 12 showing an improvement in quality of life and impact compared to placebo, and also importantly an improvement in fatigue, which is obviously a really big issue for patients, alongside the pain and the more specific joint pain things. When they looked at physical and social functioning, so the different aspects of the SF36, they showed good improvement in treatment groups compared to placebo, and the same across the different PsA scores. So PsA obviously looks at impact of psoriatic arthritis, but across lots of different areas of the disease and its impact. So things like pain, but also sleep disturbance, depression, and other issues. So it showed a kind of good improvement really across the board in different aspects of quality of life. So this is obviously really useful data to go alongside the clinical data. We've seen already that it improves disease activity in patients with active PsA, and this is showing that that then is associated with an improvement in physical functioning, in mental health, in fatigue, and in pain, which you'd expect, I think, alongside the clinical efficacy, but obviously is important to be able to show. And I think that benefit in fatigue and pain is obviously particularly relevant to patients. So I think it provides a bit more evidence, and obviously, you know, we need further trials with deucravacitinib, which are on their way, but provides that potential for a new and slightly different therapeutic option for patients with PsA in that sort of TYK2 class.
So Laura, a lot of patient-reported outcomes to use. Do you use any practically in the clinic? Should we all be using PsA in our patients now? What's your thoughts on the clinic versus the clinical trial with these outcome measures?
Yes, I think I'm a really big fan of PsA. A lot of the measures that we have used in trials have been quite old and haven't really been developed with patients. When you look back, they're mostly clinicians and researchers deciding what they want to measure rather than designing it with patients. I think the PsA was really nicely designed in collaboration with patients, very much as an equal partnership. And practically speaking, it covers nearly everything that you probably need to know and that the patient is really bothered about in one questionnaire, you know, on one page of A4, on one screen of a computer. So it's very quick and feasible to do. And if you're looking at those different scores, you can also see not just a total score of 6 or 2, but actually which things are bothering the patient. You know, is their overall score quite low, but they scored very high for skin symptoms because actually it's their psoriasis that's the problem, or very high for fatigue maybe because they've got other things going on. So I think it's really useful as well to try and hone in on what particular bit is impacting that patient and therefore what you might need to do to treat that.
Sounds good. Philip, in the US, patient-reported outcomes, you probably do everything as far as research is concerned, but on a practical day-to-day basis, what's used in the US? Rapid 3 or whatever?
Mostly it's how you doing, which we call the Brooklyn hack. So I would say it's very uncommon for most clinicians to use any specific measure. I think that what this type of paper highlights is the importance of asking about pain and fatigue. And fatigue is a special issue, and oftentimes patients don't bring it up because they may not think it's relevant, but it can be a very impactful issue for patients with inflammatory disease. I think if it's all right for me to bring up the results of a fascinating abstract that was presented at the last ACR meeting from this study. It was what's called a mediation analysis, where you're trying to parse out how much of improvement of something like pain or fatigue is due to reduction of inflammation, which is how we, I think, historically have thought that's how these drugs work. They reduce inflammation, therefore they reduce pain or fatigue. But it turns out that there's a statistical method for sorting this out, and about half of the pain and fatigue improvement was due to reduction in inflammation as correlated with swollen joint count and skin score improvement. But a half was felt to be a, quote, direct effect of the drug. Whatever this means, is it some kind of central nervous system effect or what have you? This first came out with the other JAK inhibitors, where we saw pain improvement within a week or two, and clearly before inflammation was controlled. And we've also seen it now with some of the analysis with some of the IL-17 inhibitors. So I think it speaks to the fact that phenomena like pain and fatigue are complex and are not just related to inflammation, but maybe there might be some central nervous system phenomena going on that are getting improved with these medications as well.
Excellent. So we have deucravacitinib for psoriasis, but not yet for psoriatic arthritis in Australia. Laura, where do you think this is going to sit in the treatment algorithm? Where are you going to use deucravacitinib?
Yeah, and I think that's an interesting question. So obviously in psoriasis, they have had this head-to-head study with apremilast, which and it was shown to be superior, which is obviously strong data. I think our use of apremilast is pretty limited in the UK. We don't use it a huge amount because of the bar to get to apremilast is basically the same as it is for all of the other biologics. So we tend therefore to go for biologics rather than for apremilast. So I think we're not quite sure is the honest answer. So the question is, do these work for axial disease? So They're sort of JAK inhibitors, but they're sort of not. Obviously, JAK inhibitors do have data in axial disease. If these are more IL-23 type drugs or acting on that pathway, maybe they won't work for axial disease. We don't really know. So I think that's a really important question, because having more options for patients with axial disease is key. They're a really difficult group to treat, particularly if they have comorbidities like bowel disease or something. And then I think it's really how we nuance how we use the drugs, and potentially the access and reimbursement for these drugs, to think about trying to personalize it more for patients. That's something we can't really do in the UK because of our reimbursement rules. Everybody's kind of on the same level. It's very much a level pegging. You hit these criteria, you're eligible for any of the expensive medications. But I think as we move forward, we've got to work harder and study better how we personalize therapies to different levels of disease severity, different domains, tissues, and how we approach that better.
And Philip, in the US, where do you think this is going to sit in the treatment algorithm? Is it going to be an add-on drug? In our country, we have to fail 2 conventional agents to get to a biologic, and we wouldn't mind if it was methotrexate and or a apremilast or deucravacitinib before we get there. But where do you see it sitting, Philip?
So I think it has a chance for being used first line by some clinicians, especially dermatologists that like its effectiveness, like the fact that it's an oral medication once a day, and like the safety profile. And so I think there will be some clinicians that use it first line, but certainly it'll be right there as a choice for second line. And again, the fact that it's an effective oral medication and reasonably safe, at least in studies so far, is good. And one thing we haven't mentioned is that because of its alpha interferon effect, it appears to be effective in lupus. And so the broader number of diseases that it may be ultimately approved for, that leads to clinicians getting to use it more and therefore thinking about it in their choice.
And as an add-on, I see a lot of apremilast added to biologics in the US.
Yeah, we are doing some combination therapy, and I can imagine this being a pretty ideal one to be used in that way if we can get around the formulary manager saying no.
Like the rest of the world. So thank you very much for joining us for this PsA podcast, brought to you by the Immune-Mediated Inflammatory Disease Forum. Really hope you've enjoyed it and found it useful. If you did, don't forget to subscribe to our channels on YouTube, Spotify, SoundCloud, or wherever you get your podcasts, so that you don't miss any future episodes. If you want to read more about what we've discussed today, visit www.imidforum.com, where you'll find detailed summary slides of each of the papers. We look forward to catching up with you next time. Thank you very much to you both.